Today I'm going to give it hold on a second. Let's put this over here so I actually see my own screen. There we go. Today I'm going to be giving you guys a talk about Chiari malformation and syringohydromyelia, including some clinical insights. This is really an overview. It's not meant to be comprehensive. If we wanted to start to be comprehensive, it would take an entire conference and many, many days to really talk about all the aspects. So Chiari is actually not really a malformation, and it wasn't really first described by Dr. Chiari, but it's really a group of abnormalities that involve the contents of the cervical medullary junction that results in or associated with a continuum of herniation of the hindbrain contents through the opening at the base of the skull called the foramen magnum. Oliver Dallinger was the first person who coined the term syringomyelia in 1827, where he described a cavity in the spinal cord that was actually the result of multiple sclerosis. So not typically the type of syringohydromyelia that we would be talking about associated with Chiari malformation. Professor Cleland was the first person who described what we call a Chiari malformation now, 10 years before Dr. Chiari did, but he was in Scotland and not at one of the major centers, so that he did not get recognized for this discovery. And Dr. Chiari in 1891 actually described post-mortem studies of 40 infants with post-mortem hydrocephalus, who also were found to have hindbrain or malformations or deformities in the back of the brain. And one of his students, Arnold, in 1896, published a second article. And in that article, which was really the students publishing it, they acknowledged Dr. Arnold, giving it the name the Arnold-Chiari malformation. But because Dr. Chiari was really the first acknowledged person, that has now changed, and they're now called Chiari malformations again. And essentially, he described 4 different types of malformation, from type 1 to type 4. Type 4 is not really a Chiari malformation of what we talk about to this day, and it's more severe as they go on. And type 3, really downward displacement of the entire cerebellum into the cervical area, which is really not compatible with life. There's a new term, a Chiari 0, that gets displayed around. It's really not associated with cerebellar ectopia, but there is syringomyelia as if there was a Chiari malformation. And the pathophysiology of that is that there's obstruction of spinal fluid flow with the formation of syringomyelia. Frequently involves a web or arachnoid veil that is present. So anatomy of Chiari malformation, I'm sure most of the people on this talk have seen this if they've been to a neurosurgeon and looked things up. But really you have all the what's called the ventricular system, where all the spinal fluid is secreted into the brain, starting with the lateral ventricles, going down into the third ventricle. This is a midline cut of the brain, down through a narrow passageway called the cerebral aqueduct, and then outflow at the base of the fourth ventricle. And when you have a Chiari malformation, the lateral part of the cerebellar hemispheres, called the cerebellar tonsils, forms a peg-like abnormality and protrudes into the spinal canal and interferes with the normal flow of spinal fluid. So the pathophysiology of formation of syringomyelia that's associated with a Chiari malformation was really investigated and published on by Dr. Oldfield. And what really is happening is that the tonsillar shape, which is not really a malformation at all, is acquired by abnormal pulsations of the spinal fluid at the foramen magnum. And these pulsations literally push the spinal fluid through the spinal tissue and form cystic malformation in the central of the spinal cord. So the Chiari-1 malformation, which is really the focus of this talk, is a group of variations in the posterior fossa structure, size, and architecture that result in this caudal descent of the cerebellar tonsils into the cervical spinal cord, with a resulting presence of syringohydromyelia, with or without hydrocephalus. And it's important to note that Chiari malformations are the great imitators. So all these signs and symptoms that they can have can represent or look like many other things, with some common features that are the most common findings that clinicians look for when looking to see if someone has a Chiari malformation, whether it's symptomatic or not. The presentation can be very nonspecific. The natural history can be slowly progressive with stationary periods. But the initial symptomatology is often the result of bony and dural compression, or the covering of the spinal sac at the cerebellum, brainstem, and spinal cord. And with the easy availability of imaging studies such as a MRI scan, it's increasing numbers are really being diagnosed in childhood, and it's less and less common for it to be diagnosed in someone who's a young adult or older. So Dr. Millerat and colleagues did this endeavor where they collected clinical and radiographic findings for 364 symptomatic patients and kind of put this encyclopedic article really focusing on all of the different findings. But however, it's really important to note that there are really some that are much more significant and important when looking at a Chiari malformation. And just because there were this giant list of symptoms, it doesn't really mean that they are only present in patients with Chiari or necessarily are because of the Chiari malformation. Unfortunately, early on, this led to formation of a lot of groups of people who were trying to look for answers, and they would find their symptoms on this long list of symptomatology and assume that that's what they have and that they need treatment for that. Sometimes that's not really the case, and it's really important to have a good group of physicians and practitioners who are really knowledgeable and know how to deal with this and really say, is this truly a symptomatic Chiari malformation or not? And one of the examples I can give is people who have headaches and can have headaches for many reasons, and many people get imaged. And sometimes you will find someone who has a headache and has an asymptomatic Chiari malformation, and the headaches are actually not from the Chiari malformation. So signs and symptoms, there's really four categories, those that are related to brainstem, spinal cord, cerebellar issues, and dural issues. The most common presenting symptom in patients with Chiari is neck pain and headache that comes on with straining and coughing. It's mostly occipital, or back of the head, and upper cervical, top of the spine. It's exacerbated by pressing down, or what we call a Valsalva maneuver. In little babies, can result in persistent crying, irritability, or arching of the neck in very young children. The reason they're doing that because this maneuver tends to decompress that area and decrease the pressure from the cerebellar tonsils on the covering of the brain, because the brain itself doesn't actually have pain receptors, the covering of the brain does. And then the newest finding, really central sleep apnea. There's different kinds of apnea where you stop breathing during sleep. And some Chiari patients can have actually central sleep apnea. Cerebellar dysfunction, much less common, but can occur in 11% of kids with Chiari malformation. It's really a downbeating nystagmus that's enhanced when you look to one side or not. There's different kinds of nystagmus. Ataxias, where there's difficulty with walking, is rare, but can happen. I myself have seen a few, but it's not so common because most Chiari malformations are not secondary acquired Chiaris. They occur in utero, the symptomatology occurs slowly, and there's a lot of overlap in brain circuitry that prevents formation of ataxia. Spinal cord dysfunction and syringohydromyelia can actually occurs in up to 60% of patients, frequently associated with scoliosis, an abnormal sensory level, increased tone, or what we call spasticity, dysesthetic pain of trunk and extremities, where you have this abnormal pain sensation in the arms and legs as a result of the syringohydromyelia, and dissociated sensory abnormalities, where you can have loss of pain and temperature on one side of the body and loss of fine touch on the other side of the body. I mentioned scoliosis. It can be reported in up to 31 to 50% of patients who have syringohydromyelia, not all patients. Its incidences can be as high as 87% of those who are presenting with a symptomatic Chiari, less than 16 years of age. Their curve is very different. Not everyone with scoliosis has a Chiari and syringohydromyelia. They have a single curve as opposed to double curves in patients who have idiopathic scoliosis. It can be rapidly progressive, and the curvature is different. We talk about a convexity to the left or right. In patients with a Chiari, it's actually convexity to the left. Brainstem and lower cranial nerve abnormalities, a whole list of things that can happen, which are less common. And so we really give different weights to different signs and symptoms. The strain headache is the big one and one of the most significant in saying if a Chiari is symptomatic or not. Balanced, associated pain and temperature, nystagmus, syncope, and then this pain in different areas, other kinds of headaches, poor sleep, other things, less likely to be a cause of the Chiari. And sometimes, you have patients who are reading a lot of Chiari sites, and I call it the med school syndrome. A lot of medical students, as soon as they hear things, they start associating them with themselves and start overthinking things and say, well, I must have a Chiari because I once had a headache in the back of my neck and other things. So someone who's reading a lot of Chiari sites and reading a lot about this, or they have an issue with depression or anxiety, I sort of downplay some of the symptomatology they have and really determining if this is the symptoms that they have is truly because of the Chiari. So the investigation, MRI, is very critical in this, provides visualization of the back part of the brain and the spinal cord. In the old days, people used to do other types of imaging where MRIs were not as available. 1/3 of syrinxes can't be demonstrated except for on an MRI scan. And then this new techniques in looking at flow of spinal fluid can be very helpful in determining the altered dynamics and obstruction of CSF flow that we'll talk a little bit more about during the presentation. So radiographic criteria, there's lots and lots. I didn't put all the different criteria from different investigators and how people came up with it, but really it's whether a single cerebellar tonsil is herniated 5 millimeters or more, or bilateral tonsillar herniation of 3 to 5 millimeters if there's an association with other abnormalities, not just in isolation. Pointed cerebellar tonsils, and then crowding of the cervicomedullary junction, that area where the spinal cord and the cerebellar tonsils are exiting the bottom of the skull going into the spinal canal. So I spend a lot of time talking to patients and reassuring people who come to see me because there's this minimal, what we call tonsillar ectopia. A little bit of the tonsil is lower than the average person, and they're really not symptomatic from anything. And parents are really, really scared and upset and thinking that their child is going to need surgery where they have no symptoms and they actually don't even have a Chiari malformation. So the symptomatology and who becomes symptomatic with cerebral tonsillar herniation depends on a lot of different factors. And I talked about the shape of the posterior fossa. So you can see over here, the back of the part of the floor of the posterior fossa, it can be raised too much, making too little space, and then a cerebral tonsillar herniation. You can have something called basilar invagination, where there's settling of the front of the spine into the cranial cavity, resulting in narrowness and a Chiari malformation. You can have this roof of the posterior fossa where the angle of this roof is very steep, resulting in decreased space. And you can have secondary issues like arachnoid cysts. You can see that here, pushing the cerebellum and resulting in a secondary Chiari. So not every Chiari is a Chiari. There's lots of different shapes and different ways that you need to think about treating it based on multiple different factors and findings in a patient who's actually symptomatic. So there was an international survey, it's quite old now, of management of Chiari malformations and syringohydromyelia, the Child's Nervous System journal in 2004. And the consensus statement, not a huge amount has changed, is that no operation should be performed in an asymptomatic patient with a Chiari-1 malformation. If there's significant concern, they should be followed up to make sure that they don't become symptomatic. Surgery should be performed in patients with Chiari-1 malformation when scoliosis and syringohydromyelia are present together. So scoliosis is, when it occurs with a Chiari, you assume that it is because of the Chiari malformation and other reasons as well. But there was no consensus reached on asymptomatic patients who had a syrinx but no scoliosis. And that can be quite subtle, because do you follow someone, and if they start developing scoliosis, treat them or not? And most people would say if you do have syringohydromyelia and a Chiari, even if you don't have scoliosis, you should probably do this surgery to prevent the secondary complications. So different kinds of MRI, a phase contrast MRI scan can be useful in preoperative decision making of what type of a surgery you do and what the anatomy is and how much of a surgery you do. Normal preoperative CSF flow at the cervicomedullary junction. If you see someone who has a Chiari but a very big opening and they have good spinal fluid flow around everything, the chances that their symptomatology is because of the Chiari and that it will go away with the Chiari operation kind of decreases. It's not perfect, but it kind of points to there's something else going on. Obstruction of CSF flow at the foramen magnum, as well as lack of improvement of CSF flow postoperatively, can both assist the clinician in their surgical decision making using these CSF flow studies. Lack of rapid improvement of syringomyelia in the context of improved CSF flow is reassuring. So syrinx doesn't go away right after surgery. It takes time for it to go away. And when you see that there wasn't good CSF flow at the cervicomedullary junction, now you've seen good improved flow, you know you have time for the syrinx to continue to improve. So this is kind of an article, issues that still need to be revised, indications, timing, and the specifics of the procedure. But success is really considered the alleviation of symptoms, reduction of the syringohydromyelia cavity, the syrinx may not completely go away, and arrest or remission of the scoliosis. And that's one of the big things that, not only by doing the Chiari and treating the syringohydromyelia, someone who has scoliosis, it may go into remission or even improve. If you try to fix a syrinx, or if you try to fix scoliosis that's continuing to progress, if you haven't treated the Chiari, the fusion procedure may not be effective. So the goals of surgery are to restore the integrity of the CSF flow at the skull base, restore normal pressure relationships, establish a pulsatile subarachnoid cistern in the posterior fossa, and relieve brainstem compression. We talk about the different surgeries and ways of doing this. The extent of surgery is highly variable. You can do a bony decompression and how much bone you take out, partly a measure of the actual abnormality and what everything looks like on imaging, and experience of the surgeon doing this. In some patients, you open up the dura, and others you don't. An onlay patch, whether you need to put a patch after surgery or not. In some patients who have settling of the brain, you actually may even need to do an anterior decompression and infusion, but less and less common. In some patients, you have to still put a shunt in despite opening things up, because they're scarred enough that still they have a problem with hydrocephalus. And this shrinking or resection of a gliotic cerebellar tonsil that is abnormal, and you really do need to do that because you just can't get enough space for the spinal fluid to flow normally. We do know that patients who have mild neurological deficits who are treated early have a favorable outcome. 85% of patients presenting with headache only are improved by the operation. And 81% of patients with foramen magnum compression also improve following surgery. The preoperative signs that are predictive of less favorable outcome, meaning that some of their symptoms may be relieved but others may not, is if you've already had atrophy or death of muscle cells or reduction in muscle mass. That means that there's enough damage to the spinal cord that you're not going to get everything back. Presence of ataxia, nystagmus, facial pain and abnormalities, difficulty walking, pain and temperature sensation loss, and having had the symptoms for over 24 months. So how do I do it? Clinical history and neurological exam are very, very important. Frequently, we'll have a pediatric neurologist or geneticist available if there's any questions. And I'm going to hold the questions until the end, so don't be upset if I'm not answering them right away, and then we can kind of look at those questions and review them. Careful review of the anatomy on the MRI scan, really understanding the pathways of spinal fluid flow and what's going on. Considering other procedures that may be needed in addition to the directly addressing the Chiari malformation, and then suboccipital decompression, taking the bone off, and C1 laminectomy for treatment, and then also deciding whether we need to do a patch graft and we need to do an intradural exploration that I personally reserve for kids who have a syrinx without adequate CSF flow or failed initial surgery where the initial decompression was not sufficient. So, I kind of talk a lot. I hope this is not gruesome for some of the people watching this. This is all beautiful to me. This is beautiful anatomy. This is a picture of a child who had a Chiari malformation. And you can see that it can be very, very subtle. They actually have this little web or membrane at the outflow, kind of acting like a parachute and blocking the flow of spinal fluid. And we open this membrane up, and that actually treats the Chiari malformation. It's also important that you really understand someone who is symptomatic and just doesn't have a Chiari malformation. This is a child who had a asymptomatic Chiari, had an operation at another center just because they had a Chiari malformation. And following this decompression, they had this on-leg graft and they got scarring. And then after the surgery, went from a asymptomatic Chiari now to a symptomatic Chiari with syringohydromyelia. And when we looked and they came to see us, we looked there and we saw the outflow was all scarred in. And we actually opened this up and their syringohydromyelia went away. Let's see if, we talk about secondary Chiari malformation. Here's a kid with a big cyst in the back of the brain. You can see over here how everything is pushed and everything is plastered over here, blocking the flow of spinal fluid on this MRI scan. And then after surgery, this doesn't completely go away. We're fenestrating it, but you don't have this compression and spinal fluid can flow easily, and their symptoms were actually relieved. Here's another patient with another arachnoid veil. We didn't get a CSF flow study before because they already had this imaging studies before they came to us. We expected that there was a veil here. We went over and opened this up. And after surgery, over several months, they had an improvement and resolution of these findings on their MRI scan. Like I said, the syrinx doesn't go away right away. Here's a flow study. You can sort of see the opening we created in this veil and spinal fluid kind of escaping. But knowing that this was all working and that it was adequate on this MRI scan, we felt comfortable waiting for some time until the syrinx continued to decrease over time. Okay, I think I'm probably over my time.
All right. Well, thank you so much, Dr. Danielpour, for that presentation and that just enlightenment into a little bit more about Chiari. So we've got a few questions here in the chat that I will ask now. If